Hi, my name is Gabrielle Goddess, and welcome to my patient care presentation. I'd like to kick off this presentation by first introducing you to the patient we'll be discussing today. He's a 78-year-old male. He lived at home independently. He was a smoker for about 25 years until he quit in 2010. So it's been a little while since he's picked up a cigarette, but still 25 years worth of damage. He was admitted to the emergency room with shortness of breath. He does have a history of COPD, hypertension, and does have past admits with shortness of breath. The last admit he was in, he had a chest x-ray done. They found a pleural effusion, and they had to do a thoracentesis to drain the fluid. They recovered about 1,500 milliliters total, and he was put on a diuretic. Recently, he was diagnosed with congestive heart failure, literally the day before I had the pleasure of working with him. He does have a reduced ejection fraction and was put on a fluid restriction of 1,500 milliliters. He does also have a history of high blood pressure and is on antihypertensive and blood thinners. How does he compare? Looking at his age, he's right on track for both COPD and congestive heart failure, as COPD is usually diagnosed over the age of 60, and he was diagnosed in his mid-60s. Congestive heart failure is usually not seen until over the age of 65. This could be due to lifestyle choices, a natural stiffening and weakening of the heart walls, or in my patient's case, we're looking more towards that COPD that he was diagnosed with, as well as some of the smoke damage. How common is it? Nationally, it's a lot more common than we would like. About 5 million people in the U.S. currently are struggling with congestive heart failure. It is the most common diagnosis in patients hospitalized over the age of 65, and it contributes to 1 in every 9 deaths in the United States. Locally speaking, I broke it into counties, and there's a very cool map of that on the next slide. In Hamilton County, where we were for the hospital, was 179 to 105 people die of congestive heart failure per every 100,000 deaths. This seems like a lot, but compared even to its neighbor Claremont County, it's significantly better. Claremont County averages anywhere between 205 to 230 deaths from congestive heart failure per every 100,000 deaths. And those numbers came from the CDC. It's not more common than men, however, it looks like it. The prevalence is similar in both sexes, however, men are usually diagnosed younger, and so they live longer after the onset, making it look like there's more men with congestive heart failure, but ratio-wise, they're about the same. Comorbidities for these, my patient had COPD, smoke damage, and a history of pleural effusion and hypertension. COPD is a really big player because it lowers the oxygen level in the blood, puts more stress on the heart, raises blood pressure in the arteries and the lungs, puts excess strain on the right ventricle of the heart, which can cause it to fail. Damage from smoking also can do that because of the vasoconstriction and weakening of the vessels. This is that really cool map that I was talking about previously. It shows heart failure death rates from 2018 to 2020 based on county. I drew an arrow to both Hamilton and Claremont. You can see that Hamilton's not the worst. It's this nice little peach color, so it's second best. Claremont County, its neighbor, however, is glowing bright red, not doing as hot as its neighbor. I thought this was a very cool and educational map for the topic. Let's talk literature. The first 2 articles I'm going to mention are based on pharmacological treatments. The first one is centered in the idea of using cardiac myosin activation in the treatment of congestive heart failure. This is a new drug class, or relatively new. It affects the cardiac sarcomeres rather than enzyme inhibition. And this unique mechanism of action allows for improvement in systolic function due to prolonged myocardial systole and increased stroke volume without affecting the heart rate or velocity of the contraction. This would be a big step in helping our congestive heart failure patients. The second one is the use of a diuretic to help excrete sodium, chloride, and potassium, as well as it having a really quick onset time makes them an easy addition to heart failure treatment regimens. Let's continue talking literature, but these are centered on nursing interventions. The first article was called Supportive Care Interventions to Promote Health-Related Quality of Life in Patients Living with Heart Failure, a Systematic Review and Meta-Analysis. This centered on the idea that nurses, or us as nurses, should be providing emotional support, educating our patient on self-management to help promote them being a part of their own healthcare. And this was done with the aim of decreasing depression and anxiety in our patients. I thought this was a great article to really help bring our patients into their own healthcare and provide that support that not everyone has, and even if they do have, just being a strong backbone for your patient. Advocating for them to be a part of their own care. The second one was called The Effect of Family Nursing Therapeutic Conversations on Patients with Heart Failure and Their Family Members. This means that not only having those therapeutic conversations with just your patient, but also bringing their family into it and providing them with the power and education to be in that patient's healthcare team, bringing them together and helping us help them help their loved one, if that makes sense. Helps keep patients on track with their treatments and improve their psychological well-being both over long and short-term timelines. The third was to help our patients be more a part of their care, and this can be done using modern-day technology, whether this is MyChart or phones with apps that center around heart failure or around their treatment plans. Just getting them connected and bridging the gap between healthcare providers' information and patients' information. And this came from an article called Patients' Needs and Perspectives for Using Mobile Phone Interventions to Improve Heart Failure Self-Care, a qualitative study. The last article I'm going to discuss, I saved my favorite for last. This was centered on collaboration. This was by a lady named Mary P. Hansen. She wrote an article centered on the idea that every time there is a milestone in a congestive heart failure patient's journey, including diagnosis, you should call for a consult with palliative care. And this showed significant results in symptom management, symptom burden, patient quality of life, and reducing the number of readmissions for heart failure patients. Not to mention, it helps them get to thinking about advanced care directives and things like that, so when the time does come, if we're not rushing, it's already done, everyone knows what they want, and it's just seen as really beneficial for heart failure patients. What's the plan? Starting with my assessment, I found that my patient's blood pressure was high. This was before medication administration, but it was about 156/92. His lung sounds were diminished. Couldn't hear any crackles, but the diminished was likely due to fluid buildup that's secondary to CHF. After listening to the heart, both S1 and S2 were audible. However, S1 was a bit softer than I would normally like, which is secondary to CHF. And my echo attachment noted that the patient was in AFib. This was later also seen on his telemetry monitor, later meaning when I got out of the room, as well as confirmed by my RN. My focused assessments stayed on cardiopulmonary, perfusion, and then I kind of did also make sure to stay on my cognitive assessments, making sure that he was still with me every time I went in the room. My goals were to get that blood pressure lowered. I kept monitoring it very closely throughout the day, as well as keep close eye looking for fluid overload, or him struggling to breathe in any way. I also did educate my patient on changes and orders that were made, include his fluid restriction that was added the morning I started, and his low sodium diet. I implemented nursing interventions like education, and I carefully explained about his fluid restriction, that it was 1,500 milliliters, and that means that he needs to be cognizant of what he is drinking throughout the day. Outcome, I did get the blood pressure lowered. His AFib did stay the same, but they said that that was normal for him, as that's not abnormal for his readings. My experience with heart failure patients. This wasn't my first, but it was definitely my best heart failure patient. My previous one was also a stage 4 lung cancer patient who was going into hospice care. So his care was, instead of centered on treatment, was more centered on palliative comfort care, which made a huge difference. I did still do very focused assessments to try to keep my skills sharp, staying on heart and lung functions, as well as looking for fluid overload and perfusion issues. But overall, very different cases. This is my nursing care algorithm / decision tree. This would be what I would use again if I were to have another CHF patient. These are centered on nursing interventions and things as even a nursing student I can do, rather than the pharmacological treatments. I kind of stayed away from those when developing this tree, just because they are not in my control currently. To sum it up, the main points I hope are taken from my presentation are focused on the interventions we can implement for our CHF patients. For the nursing perspective, we can help our patients achieve better outcomes by ensuring that we meet not only their physical needs, but also their psychological needs. We can work with their physicians and discuss the need for pharmacological interventions like diuretics to help the body excrete sodium, fluoride, and potassium, as well as new drug classes to help them increase the systolic function in their hearts. But also the psychological side of heart failure. This shouldn't be done by working with the palliative care team, ensuring our patients have a good support system and keeping that support system part of their care and treatments. Plus, for those patients who don't have a support system, learning to become and be that support system for them, as well as keeping our patients included and using new age technology, and not just the medical sense, but also to keep them connected with our patients and keeping them in the loop of their own care and showing them that they are as a part of their care as we are. Not just working on them like we would a car, but rather working with them and really building a relationship of trust with our patients. Here are my references in alphabetical order. Thank you for listening.